So, Dr. Paul here. So we got a question from a on our about our YouTube channel from a person that says the doctor started me on Zoloft. What to expect from it? Why did it take weeks and months for it to work? So let's talk about that. I've talked about this before, other videos. I talk about the class. The most commonly given class is the SSRIs, Selective Serotonin Reuptake Inhibitors, which basically, what they do is they attach to the serotonin site. And the problem is that it forces the serotonin to cross the membrane and go and connect into the next cell. And it prevents it from going backwards, which is good. So what to expect from it? There's several things with that question. Well, with Zoloft, is one of the most common. So when someone starts on SSRI nowadays, it's usually Zoloft or Lexapro. Those are the two most common given. Some Prozac, some Trintellix, which is the newest one, which is a good one. But usually it's those two. So number one, let's talk about some myths. Let's talk about misconceptions about this subject. There's a lot of them out there. And in my first book, I have a whole chapter. It's called Myths and Misconceptions. I talk about, I think, a dozen different things. Number one, I talked about SSRIs. They're not always the best first-line medications. That's like sacrilegious for me to say that in this field, because every other doctor except me and probably a rare other doctors think that they're not the best first-line medication. And I know you might get sick of hearing this, but SNRIs are usually better, not always, but usually. But if it's not, then we go back to SSRIs. But the SNRIs, when you balance norepinephrine, you get better results sometimes with anxiety and with physical symptoms. So the myths are that it takes weeks to work. That's nonsense. None of these medications take weeks to work. That's why do the books say that? Hard to know. Maybe if the doctors are they just babying the dose too much and not getting aggressiveness with titrating the medication? That might be part of it, but it's really a misconception there that people think that when these medications, you were talking about within a week to 2 weeks to work at the most, usually within a week, at the latest within 2 weeks. So it's much quicker than you're going to hear. You also have to dose things correctly. Now, an SNRI, it starts working within about 2 to 4 days. And so usually with an SNRI, I can get someone better within 1 week. Because you have to titrate it correctly, you have to dose it correctly. And then with SSRIs, when they work and they're good, within a week, 2 at the outside, like I said. So that's a big myth. And then the other myth out there is that, and you're going to read this if you go online, you're going to see these, we call black box warning of suicidal ideation, meaning these antidepressants can increase suicide risk. Can they? Rarely. Much more often they do the opposite. Much more often they save lives, they reduce suicidal thinking, because if you treat the depression, then suicidal thinking goes away. The other thing to think about with the suicidal thinking is that it might not be depression, it might be a bipolar, or it could be a bipolar depression. And bipolar disorder is a little bit more difficult to treat, because you have to put in, because the antidepressants alone aren't going to do it. You have to. They might be part of the treatment, but that you have to put in mood stabilizers to help with the bipolar part of it, and that can sometimes just be really bad depression that's just not getting better with SSRIs, with SNRIs, with Wellbutrin. And so if you get someone who's just not getting fully better, or let's say they get partly better but not fully better, that's a hint of adding something like a mood stabilizer. And so a lot of the times with suicidal thinking, it's much more common with bipolar disorder than with what we call unipolar disorder. Now, unipolar disorder are things like depression disorders, anxiety disorders. Those we call unipolar because they don't have the upper pole. So bipolar means two poles: the lower pole, which is the depression, the upper pole, which is the mania. like the racing thoughts and the irrational paranoia, things like that. So that's a couple myths there. That and the suicide thing is a big myth. And again, the problem is when people read these things, they may just they talk themselves out of taking it, or they just get afraid, or they're feeling better, but then they read that and they go, oh, maybe I'll take it away, because then then they stop taking it and then they crash again, and because they're afraid of what they read. So it's unfortunate that the government forces the companies to put that warning on, because it's very, very deceiving, because it's not always really what the truth is. And it's important with the subject, because people are suffering, and people with depression, with anxiety, they're suffering, and they need to get better. They should be getting better, but sometimes the fear stands in their way, because they get bad information from the internet, from Googling, from trying to look at studies and try to be a scientist when you don't have a scientific background, and trying to figure it out that way, which is just not going to work. So the best thing is to go to a doctor you trust, who knows what they're doing, who understands the subject. That's your best bet, is to find that doctor and stick with them. And then you got to remember, the doctor's got to be making progress. Even if it's not perfect within the first week or two, because sometimes one medication within a week or two, that's all they need. That's it. And that can definitely happen. I have a lot of people on one thing and they're perfect, but usually it takes follow up, and that takes communication. So hopefully your doctor is able to get you in and follow up and get things right for you. But that's what to expect. I mean, I think what to expect as far as side effects with SSRIs like Zoloft. You got to watch for apathy, meaning numbing, like a numbing effect, feeling like lack of emotion, sexual side effects, fatigue, weight gain, rarely, but it can happen. So we don't want that. But if you get benefit from an SSRI, and let's say an SNRI is not better or not tolerated, and you're back, so once you figure that out, the S and the N part here, then if you have residual symptoms, then it's a matter of adding another piece in there. And so that's what a lot of what I do is putting things together to get us to our goal of remission, which means people are in a great state, the depression's gone, the anxiety's gone, everything's better. That's my goal for every patient, and I don't stop till I get there. That's what what remission means, and that's the goal for all of my patients, And so in every visit, if they're not there, I try to figure out how am I going to get them there by next visit. So anyway, but that's kind of what to expect. That, again, SSRIs are probably my most common question I hear about, because of the fact that again, so many doctors think that they're the be all and the end all, and unfortunately, a lot of doctors, they buy into the myth about this. Well, give it a few months more and maybe it'll get better. And the problem is they started like, okay, we'll start Zoloft at 25 or 50, and then we'll go to 75 the next month or two, and then we'll go to 100 in a couple months, and then we'll go to. So they're taking like months and months to try to figure out the dose of one thing, and that should have been done within a few weeks at the most. And so they're wasting a lot of time with trying to do things way too slowly when they shouldn't do that, and they don't need to do that. But they're doing it because they're buying into the myths, and so it should be, what I do with people to get to things right away quickly. I move very quickly with dosing, titrating the dose, adding another one, getting people figured out. So everything here is clicking. Everything is correct. So that's the goal. And don't be satisfied. Don't be satisfied with I'm just kind of okay, or I'm just a little better. That's not what you should be. You should be much better than that. Any questions about this, feel free to comment and feel free to ask questions. I can always address them later. Thanks.